Hi, very good morning, everyone.
Good morning.
We are meeting on 7th of September 2024 for a very important topic. We have been missing some few sessions because of the annual commitment from CMAAO. Today we are talking about infection control and prevention of hospital-acquired infection. I think this is one of the very important topics we all ask when we get admitted to the hospital. We have Dr. Yash Javeri to talk about these important session. Dr. Yash Javeri is Director, Critical Care and Emergency Medicine in Regency Super Specialty Hospital in Lucknow. He's a MBBS graduate from Government Stanley Medical College from Chennai in 2000, gold medal diploma in anesthesiology, ISCCM diploma in critical care medicine from Shri Gangaram Hospital, Delhi. In 2008, infection control online training from John Hopkins Fellow, Indian College of Critical Care Medicine, FICCM Fellow in 2018, Society of Neurocritical Care. His area of interest is sepsis, ethics, traumas, critical care, intensive care in resource limited settings. He is a vice president for Indian Society of Critical Care Medicine, Dean for Indian College of Emergency Medicine, past Vice President of Society of Neurocritical Care, past Vice President of Indian Society of Toxicology, past Chairman of Society of Critical Care Medicine, Delhi NCR, is a convener of Indian Sepsis Forum. Sir, we are pleasure to have you on this topic. Over to you.
Thank you, Dr. Saurabh, and thanks for the big opportunity and providing a wonderful platform. And we have a lot of stalwarts in their fields joining us, chairpersons and dear friends. I'm going to discuss about infection control and prevention of hospital-acquired infection. A very important topic for all of us, regardless of what specialty we practice, whether we are a clinician or a nurse or a paramedic or a patient. So it matters us all alike. No conflict of interest, including financial interest, funding, or other conflicts of interest with respect to content of this talks. The objectives of this talk will be to understand hospital-acquired infection. What are these infections? What is the chain of infection when we acquire this hospital-acquired infection, and how to break this chain of infections? What are the common routes of transmission and how to curtail those routes? We'll discuss basics of standard precaution, and further we'll elaborate on differentiate in the categories of transmission-based precautions, and then the learning points from today's presentation. We all know this, an ounce of prevention is worth a pound of care. This applies very much to healthcare, especially infections. Infections are easier to prevent than to treat, especially if we are in a country like India, Southeast Asia, where the incidence of MDR is very, very high. If we have a hospital-acquired infection, not only the outcomes are bad, but diagnosing the real bug, the sensitivity pattern, and trying to find a cure for those bugs is a very, very hard task. And at times we isolate bugs in hospital-acquired infection where we have nothing to offer to patient, and we are on the last line of antibiotics for those patients. So we need to invest on infection prevention rather than on infection management. Sadly and ironically, all our priorities, all our meetings and research is more on infection management rather than on infection prevention. This needs to be changed. The purpose of this talk, we understand infection skill. Acquired infections are more lethal because the patients are compromised, they suffer from some other disease. These are mostly MDR bugs where we have limited options to treat. The host is compromised. Also, we need to look at our safety. We understand healthcare professionals are at higher risk of many MDR infections. MRSA, MDR gram-negative infections are higher in healthcare professionals whenever they acquire an infection. MDRO is the biggest challenge which we are facing in India and in most of the developing and low middle income countries because the sensitivity is worsening day by day. Most important, HCI can lead to morbidity and mortality, and this is preventable mortality, and we need to prevent these complications at every cost by every means we can utilize. Because we are into business of saving lives, patient not suffer a second injury by virtue of coming to hospital. What is happening in many parts of the world, whatever the disease the patient comes to, patients is coming with multi-system trauma or toxicology or pancreatitis, the final common pathway for death and demise becomes a hospital-acquired infection. Almost 50% of the patients in lower middle income countries suffer with various nosocomial infections, and we need to stop this by every means we have in our hand. What shocks most? The illness and deaths that results are largely preventable. So these infections are preventable infections. And we need to be aware about these infections. We need to be aware about the measures. Clinicians, paramedics, and the patients, everyone has to work together to prevent these infections. Going on to the definition of healthcare associated infection or nosocomial or hospital infection, called by various names. Earlier, it was hospital-acquired infection, but we understand the infection could be just acquired by virtue of exposure to healthcare, like a dialysis facility or a patient coming to OPD for a dressing. So the terminology now is healthcare-associated infection. So whenever you take history, always ask about exposure to healthcare. It could be a home-based dressing, it could be home-based antibiotic therapy, but exposure to healthcare is a risk factor for MDR infections and for hospital-acquired infections. So HCAI is defined as an infection occurring in a patient during the process of care in a hospital or other healthcare facility, which was not present or incubating at the time of admission. This includes infections acquired in the healthcare facility but appearing after discharge. If we take the spectrum of surgical site infection, they are generally late to present. So we have to be on a vigil while the patient comes for a follow-up visit to the surgical clinic. And also occupation infections among healthcare workers of the facility are attributed to this. COVID, if it was acquired during our duties in hospital, it became a hospital-acquired infection. So we have to be aware that infection could be for the patient, but it could be an occupational infection happening to healthcare workers by virtue of working in the healthcare facility. Healthcare is a burning platform. And what is adding to the fuel to this fire is hospital-acquired infection. This is the biggest challenge we all are facing, whatever specialty we practice. The problem is obviously more in the critical care areas, the ICUs, because these are harbingers of infection. More infect patients, long stay patients, immunocompromised patients, more antibiotics, and this becomes a vicious cycle for having MDR organisms and hospital-acquired infections. Why should we prevent healthcare-associated infections? Because we are in healthcare to save lives. Why did we join healthcare as our passion profession? To save lives. Having a patient get a healthcare-associated infection in the course of treatment is devastating. It's very demotivating for the healthcare professional and will have tragic outcomes. The rates which we see, especially in the LMIC group countries or in the developing world, are just a small tip of the iceberg. For every case, there are hundreds to thousands of cases which are not reported. Many of the healthcare facilities do not have a robust system to report, and most of the reports, the healthcare associated infection data is weak and a non-serious data, if I call it. And our actions are based on that data. So garbage in, garbage out. We think our CRBSI rates are low, but there is gross underreporting because of various challenges. At any time, hundreds of millions of people worldwide are suffering from infections acquired in healthcare facilities. In modern healthcare facilities in the developed world, 5 to 10% of patients acquire one or more infections in hospital. So the data for developed world is 5 to 10%. In the developing countries, the risk of HCAI is 2 to 20 times higher than the developed countries. And the proportion of patients affected by HCAI can exceed to 25%, and many centers it has reached to almost 40%. In the ICUs, HCAI affects about 30% of the patient, and the attributable mortality because of HCAI in ICU is 44%. This is a huge number to tackle. We have been reading about it, the media keeps on talking about it. Initially, we thought media is overemphasizing it, but they are doing it for a good cause. And probably, if patients become aware about prevention of infection, the healthcare professionals will also gain more seriousness. The infection control team will have some more muscle, and we are probably we handle HCI better. Alarming figures countrywide. Some reports are from Chennai, some from north of India, some from central India. The rates are mind-boggling. 25% is the round-off figure for HI in India. What is the bigger problem? Indian healthcare already faces the challenges of community-acquired infection, and we have a lot of gram-negative infections, MDR infections already there in the community. Added on this, we have a bigger challenge of nosocomial infections in our hospitals. 40% of all infections in Indian hospitals are nosocomial in nature. So you can understand what numbers are we talking about. Percentage of patients in ICU, if you look at, 40% of the patients with infections are community acquired and 46% are nosocomial infection. The impact of HAI, more serious illness because MDR organisms, compromised host, lesser antibiotic options, prolonged stay in ICU, in the ward, in the healthcare facility, long-term disability, excess morbidity and mortality, financial burden, loss of confidence in the healthcare. It can lead to legal issues, and it has led to legal issues many a times. High personal cost on patient and their family. So the cost ultimately is not only financial, it costs the life of a person or a limb of the person, or it could be an eye or brain infection, it could be anything. So we have to always remember there is a person behind the name, there is a name behind the HI, it is just a number. Always remember, some is not a number, soon is not a time. Every life matters. So we have to take every step to prevent each and every HI which happens in our healthcare facility. The very first requirement in a hospital is that it should do no harm. Primum non nocere. So we have to stick to this adage and try to minimize or try to bring the HI numbers to near zero as close as possible. The second part of the talk, to understand the problem, the factors which influence the development of nosocomial infection. The microbial agents, they are there in the hospitals. Hospitals cannot be sterile. We cannot make healthcare facilities sterile. If we overuse microbicidal agents, then these microbes will have selection pressure and more resistant organisms will be there. Patient susceptibility, yes, most of the patients in hospital are susceptible. Bacterial resistance, bigger issue in some places. And the environmental factor, the engineering factor. This is what we can control. Good hand hygiene, good air handling unit, proper distancing of bed, sunlight coming into the ICUs, and many other factors which we all are aware about. So these factors are controllable factors, and we should take every effort to control this. And what we can do, we can decrease the exposure of patient to the microbial agent. Shorter hospital stay, shorter ICU stay, shorter stay for the devices, good hand hygiene, use of gloves where and when required. Virulence of agent, wound or devices, immune status of the patient, age, comorbidities. These are the problems which add on to the HAI dimension. What are the common sites and sources of HAI? The biggest problem which leads to highest morbidity and mortality is bloodstream infection. Bloodstream infection could be from a central line or a peripheral line, or at times it could be from a device also like a orthopin. Catheter associated UTI, the commonest HAI, although it can also have serious morbidity and mortality, but generally less serious unless it is associated with an MDR infection. Ventilator associated pneumonia or ventilator associated events, infective events, again a big problem. Surgical sites infection, grossly underreported. Skin and soft tissue infection, CNS infections associated with the EVD. These are the common healthcare associated infections. The source could be endogenous, like activation of tuberculosis, herpes simplex infection, herpes zoster infection, or could be exogenous. Wide variety of these infections are exogenous, bacterial infections, but we understand the gamut of infections are not restricted to bacterial infection. It could be fungal infections, at times parasitic.
I think there is voice breakage.
Yeah, I think so.
We are not hearing.
Dr. Javed, we can't hear you. So we are just waiting for Dr. Yash Javed to be back.
Can you hear me now?
Yes, we can hear you now.
Yes, yes.
Okay. So the sites and sources of HAI, it could be bloodstream infection from central or other peripheral cannulas, catheter-associated UTI with a urinary catheter, ventilator-associated pneumonia or infective VAE, surgical site infections, skin and soft tissue infection. The source could be endogenous as for herpes simplex, tuberculosis, at times herpes zoster, or it could be exogenous like for vast variety of bacterial infections, at times Candida auris, and other parasitic infection can also lead to exogenous HAIs. What are the most frequent sites of infection? UTI 34%, urinary catheter and urinary invasive procedures are the highest risk factor. So longer these catheters stay or devices stay, higher are the chances of hospital-acquired infection. Advanced age, underlying disease, urolithiasis, pregnancy, diabetes are other risk factors. For where mechanical ventilation, aspiration, nasogastric tube, recurrent intubation, poor hand hygiene, poor suctioning technique are the risk factors. Surgical site infections, inadequate antibiotic prophylaxis, incorrect surgical skin preparation, inappropriate wound care, and lack of hand hygiene. For blood infections, generally it is associated with a vascular catheter, but other devices like an orthopedic pin or any other device like a valve or a mechanical device in the heart can also lead to bloodstream infection. Severe underlying disease, immunocompromised status, more invasive technologies, lack of training and supervision for the basic HI prevention bundles can lead to bloodstream infection. So what is common in all this? If the device stays for a longer time, if hand hygiene is poor, the risk of all HAI is higher. So try to remove the device as early as possible. Try to follow hand hygiene almost at every opportunity. Chain of infection. We understand we need to have a bug, the organism, a reservoir, the patient, which is a susceptible person. We are also in the hospital, we are also in the ICU, but
Because we are not susceptible, we do not get these infections, although we transmit them to patients by virtue of our hands or poor techniques. So we need to break this chain of infection. Obviously, we cannot make all the zones of our hospital sterile. It is impossible to achieve. But what we can do, we can decrease the interaction between the host and the bug by decreasing the transmission rate, good hand hygiene, proper procedure protocols, removing the devices as early as possible. So what is the chain of infection? There is a portal of entry, there is a portal of exit. There is a source, which could be poor hand hygiene, poor techniques, reusage of devices. There is a susceptible host and a mode of transmission. We need to break this mode of transmission. So we need to have a good infection control program. We need to focus on environmental sanitation, hand hygiene, right disinfection and sterilization of our zones. The patients need to be exposed less to infective etiology. If we are using respiratory equipment, it should be single patient use. We should be keeping them in sterile bags. We should not be changing the devices between patients. We should have a good reuse policy in our hospitals. We need to decrease the exposure of patients to these bugs. The infectious agent. Again, good environmental sanitation will decrease the load of these infections. The susceptible host, we need to have good glycemic control, less spray. The dressing of the wound should be proper. The elderly and the neonatal population are highly susceptible. We should be taking special precaution for this high-risk patient groups. How to decrease the portal of entry? Aseptic technique, catheter care, wound care, hand hygiene. And the mode of transmission again has to be decreased. The foremost again entity is hand hygiene, sterilization, standard precaution, airflow control, proper food handling, isolation of some patients like patients with MDR infections, COVID, open tuberculosis. So these are the techniques to break the chain of infection. How to identify HAI? While any patient can have an HAI, but we need to think of HAI if the infection is not present or incubating at the time of admission. Symptoms appear about 48 hours after admission, but these timelines are not very strict because the patient could have been exposed to healthcare facility before coming to your hospital. Infections acquired in hospital by a patient admitted for a reason other than the infection. So if a patient is admitted with, say, overdose of organophosphate, and now the patient is having signs of pneumonia, you have to think about ventilator-associated pneumonia. We also need to include infections acquired in the hospital, but symptoms appearing after discharge. Occupational infections among staff of the healthcare facility, like needle stick injury or other transmitted infections which we acquire in the hospital. Sources of infection, it could be endogenous, patient's own flora, we already discussed, or exogenous. Environmental sources, inanimate objects, air, water, or food. Healthcare workers, the hands of healthcare workers, or from other patients, the patient on the next bed can also send you the infection. These are the common exogenous site of infection. Handle of the door, food trays, mobiles, computer, mouse, poor hand hygiene, poor AHU unit functional, poor cross ventilation, no sunlight coming into your ICU, or poor environmental sanitation techniques. All inanimate environmental objects can facilitate transmission. It could be the ventilator knob, it could be computer mouse, it could be the patient file, it could be the pillow, it could be the blanket which we give to the patient. So whatever we give to the patient or whatever is present at the surrounding of the patients have to be disinfected from time to time depending on the policy and what device we are talking about. So there are three basic routes of transmission: contact, Contact could be direct or indirect. Droplet, these are larger in size than 5 microns. They don't travel long distance. They are not infective over time because they do not travel long distance. Generally, a spatial separation of about 3 to 6 feet, more than 3 feet is adequate. Airborne, they are smaller and infective over time and distance. And we need to have a good AHU facility and good isolation facility to prevent airborne infections in our facility. All microorganisms are implicated, but escape pathogens, escape stands for Enterococcus faecium, Staphylococcus aureus, Klebsiella, Pseudomonas, and Enterobacter. These are the bigger challenges in our facilities. Others, E. coli, Stenotrophomonas, Acinetobacter, these are again organisms leading to a big number of HIs in Indian ICUs. But it could be any bacterial infection or at times fungal infection. So how to prevent these HCIs? Again, it can be categorized broadly into 3 categories. Standard precautions, which we have to take for every patient every time, or it could be transmission based or specific precautions based on the mode of transmission of that infection. And we need to follow a bundled approach. CRBSI bundle, WAB bundle, surgical site bundle, C. difficile prevention bundle for all of these infections. What are standard precautions or better called universal precautions? Practices that should be followed by all personnel at all times on all patients admitted to the hospital regardless of the diagnosis and presumed infection status. So these are the holy grail of our practice. Standard precaution, every patient, every healthcare professional, every time. And what are these standard precautions? Hand hygiene, personal protective equipment based on your task and based on the risk of that procedure. Safe injection practice, one needle, one syringe, only one time. And respiratory hygiene or cough etiquette. We need to follow this standard precaution for each and every patient. Also, we need to follow our facility or clinic specific policy. Like for a tuberculosis center, it could be different. For a ILI unit, it could be different. For a neutropenic setting, it could be different. But these are standard precautions which need to be followed each and every time. What are the components of this standard precaution? Again, to re-emphasize, hand hygiene, personal protective equipment, biomedical waste management, disinfection of patient care items, environmental cleaning, respiratory hygiene and cough etiquette, safe use and disposal of biomedical waste, including sharps. Again, a pictorial demonstration of the standard precaution, hand washing, gloves, personal protective equipment, depending on what risk, fluid resistant gowns or aprons, safe handling of sharps, safe handling of waste, safe handling of soil linen, and environmental cleaning. These are simple, consistent, and effective approach to infection control. We need to minimize contact with blood or body substances by utilizing safe work practices and protective barriers. And these precautions apply to all patients. Hand hygiene, we cannot emphasize more, but every opportunity we get, we should emphasize on hand hygiene. Hand hygiene is the single most effective and least costly intervention which can decrease healthcare associated infections. So we need to wash our hands of everything except our responsibility towards our patient. 5 movements of hand hygiene before touching a patient, before clean or aseptic patient procedure, after body fluid exposure risk, after touching the patient or surrounding, and remember the pen, the mouse, the mobile, the patient file, everything comes from patient surrounding and after touching a patient. So remember these 5 movements of hand hygiene. Hands of healthcare workers are the main source of transmission of infection in the healthcare facilities. Hand hygiene is the most effective, easiest, economical, and can be practiced everywhere. if we talk about hand hygiene, it cannot go beyond without mentioning about Ignaz Philipp Semmelweis, father of hand hygiene. He was an early pioneer of antiseptic procedures. He discovered that incidence of puerperal sepsis could be drastically curtailed by use of hand disinfection in obstetric clinic. The term hand hygiene includes hand washing with soap and water, use of alcohol-based products that do not require use of water, more than 60% alcohol, and it also includes no artificial nail, not using gloves for wrong indications, changing gloves between patients if required, not wearing nail accessories, rings and bangles to your workplace in the healthcare facility. Fingernails should be short, clean, best to avoid artificial nails, gels, wrap, extensions, nail jewelry, everything has to be avoided. Hands should be free of anything. Types of hand hygiene, it could be social hand washing, what we do in our homes before eating food, 15 to 30 seconds. Hygienic hand washing, 32 seconds, 60 seconds, what we talk about in HAIs. And surgical hand washing, which is a very procedure hand washing, which takes 2 to 3 minutes. Which technique, hand wash or hand rub? If you have opportunity and time to do hand wash every time, this is the best thing to do. But obviously, we cannot go and wash our hands after every patient contact. It is virtually impossible because it requires more time, need towels to wipe, we have to go to the wash basin, and we cannot have wash basin at every bedside. So we opt for hand rub, which is on the bedside. But remember, if you have a feeling your hands are visibly dirty, or if you have done a procedure, you have changed gloves, better to do a hand wash in between. And if you have used hand rub for 3, 4, 5 times, you have the feeling your hands are dirty and you have that sultry feeling, better to wash your hands in between. But obviously, every patient contact, you cannot go for hand washing. Going on to the transmission-based precautions. Transmission-based precautions are a set of infection control practices which should be followed above and over and above the standard precautions. Should be practiced handling patients infected with infectious agents having specific mode of transmission like tuberculosis or COVID or diarrheal illness. Transmission-based precautions are of 3 types: contact precautions, droplet precautions, and airborne precautions. I'll elaborate. This is a busy slide. Contact precaution. Vast majority of MDR organisms in our ICUs, we need to have contact precautions. Enterically transmitted hepatitis virus A and E, agents of conjunctivitis, contagious skin lesions, Staphylococcus herpes simplex, again contact precautions, agents of diarrheal illness like rota, cholera, C. difficile, again contact precaution. Droplet precaution, SARS-CoV-19, influenza viruses, mycoplasma pneumonia, Neisseria, diphtheria, Haemophilus influenza, viral hemorrhagic fevers, and various other viruses like rhinovirus, rubella, adenovirus. Airborne, Mycobacterium tuberculosis, measles, varicella, smallpox, Bacillus anthracis, aspergillus. For this, we need to have the airborne precautions. Contact precaution, hand hygiene, gown, and gloves are most. For droplet precaution, hand hygiene, and mask. Better to have a N95 mask if you are exposed to any of these high impact infections. Surgical mask gives you some precaution, but it is good enough for a contact precaution. For droplet and airborne, better to have a N95 mask. Airborne precautions, hand hygiene, negative pressure room, and an N95 respirator mask. Droplet precaution, many people go on with a surgical mask, but I'll again emphasize these are high risk infections, and if you are treating such patients, better to use a N95 respirator mask. Contact precaution followed when there is evidence of HI transmission by direct or indirect contact during the patient care. Clean your hands, gloves before entering the room, discard gloves after patient care, put on gown before entering the room, discard gown after remove and exit. Use dedicated or disposal equipment. If you are using stat, clean your stat with chlorhexidine, or you can use, there are small stickers which are available for the diaphragm. You change it between patients. Droplet precautions for larger particle more than 5 micron size. Cough etiquettes, transmission requires close contact less than 3 feet. So keep that safe distance between the patients and between the healthcare professional and the patient. They do not remain suspended in the air and they travel short distances. So the control is easier than for airborne organisms. Do not directly cough or sneeze on hand. Use your sleeves or elbow. And whenever you are coughing and sneezing, keep some distance from your fellow healthcare professionals. Wear a mask if you are having an upper respiratory infection or you are coughing. Wear surgical mask to limit the spread. Turn your head away from others and use tissue while coughing or sneezing. Hand hygiene after coughing or sneezing. So this is again interchangeable. Surgical mask or N95 depends on the healthcare facility and what type of infection you are tackling. Droplet precautions, again hand hygiene, PPE, we already stressed on surgical mask or N95 mask, respiratory etiquettes, patient placement, single isolation room, or you can cohort. If you have many patients with SARS-CoV, obviously each patient cannot be put in a isolation room, so you cohort those patients. Disinfection of the room once the patient has left that particular room, terminal cleaning. Airborne precautions for aerosols, which are small particles less than 5 microns, generated during certain aerosol generating procedures like intubation, nebulization. They remain suspended in air for a longer periods and they may disperse to a distant places other than at the point of generation along the air current. So the precautions, again, hand hygiene, put a fit tested N95 or a higher level respiratory mask before room entry. Remove the respirator after exiting the room and crossing the door. Room must always remain closed and better to have an empty room for such patients. PP again, to emphasize N95 at least, patient placement in airborne isolation room, ventilation, obviously it is impossible to have natural ventilation, but the airflow direction, the AHO should be nicely functional, and whenever you design these rooms, the airflow should be properly checked. And the AHU should be properly cleaned from time to time. PP, we all are aware, but to emphasize eye protection, mask, surgical N95 depend on the level of protection, gown, gloves. Ensure PPE use is rationalized and appropriate. If you're overusing it for wrong indications, again, we are generating a lot of biomedical waste. And whenever we wear or remove, especially while removal of PPE equipment, there is a risk of exposure to the biohazardous material for us also. So use in the right context only. Always clean your hands before and after wearing PPE. PPE should be available where and when it is indicated. Correct size. Select according to the risk as per transmission-based precautions. Always put on before contact with the patient. Always remove immediately after completing the task. Never reuse disposable PPE and make sure the biomedical waste disposal of PPE is correct. Clean and disinfect reusable PPE between each use. If you are having some policies like for goggles, change PP immediately if it becomes contaminated or damaged. PP should not be adjusted or touched during patient care. So the mortality and outcomes of these infections depends on what type of hospital-acquired infection we are talking about. COTI, the mortality is less. CRBSI and ventilator-associated pneumonia, the mortality is high. CRBSI, it is highest, almost 40 to 50% attributable mortality. Ventilator-associated pneumonia, again, the mortality which is attributable could be of the tune 35 to 40%. This is the frequency. COTI is 33% from the overall share of hospital infections. CLABSI, central line associated blood system infection, 13%, where 15% surgical site infection, 31%. So these are the major hospital-acquired infection. And looking at the mode of transmission, there are specifically designed bundles of care for prevention of this infection. COTI bundle, CRBSI bundle, WAB bundle, surgical site bundle. So what is the bundle? Bundle is a group of interventions related to a disease process that when executed together result in better outcomes than when implemented individually. And when we talk in context of HI, we talk about infection control bundle. There are hospital infection control bundle, there are community infection control bundles also. The common bundles we already discussed. We all have heard this story. A single arrow is easily broken, but not 10 in a bundle. So whenever you are practicing bundle care, we need to follow this in a group. And if we are not able to follow a particular part of the bundle, we should have a very strong reason and we should be documenting the reason why we are not following that particular aspect of the bundle. The common bundles: central vascular catheter insertion and maintenance bundle, COTI bundle, peripheral vascular catheter care bundle, surgical infection prevention bundle. C. difficile prevention bundle, WAB bundle, maintenance bundle for use in community also are available. I will just elaborate on one of these bundles for lack of time. Surgical site infection. There is a preoperative phase, chlorhexidine based cleaning, surgical hand wash, and preoperative use of antibiotics 1 hour before surgical incision and repeat if necessary. Intraoperative, good AHU, skin preparation again as per the surgical requirement with chlorhexidine. Intraoperative, the surgeons must change to surgical gloves after before they start the procedure. Post-operative, hyperglycemic control, proper hand hygiene. Post-operative, at times you need prophylactic antibiotics used when required. And right post-operative care, especially the wound care, has to be very, very stringent. At the end, I like to mention that infection control is not the job of the infection control nurse or infection control officer. It is everybody's business, and the patient is also a stakeholder of the infection control practice. And we have to have a patient-centric approach for all infection control infection. It is a serious business. The hospitals, the healthcare facilities need muscle and resources. What is happening? We have infection control team, we have infection control officer, but they are overburdened with other responsibility. They do not have any muscle to bite. They are non-punitive. They have no control on the practices, and we need to give them the control and the power. We need to have a kitchen sink approach. Whatever is best for that particular infection should be utilized. I will give you an example of WAB. Our WAB rates about 14 years were quite high. We were obviously bothered. So what we did, apart from the routine WAB prevention bundle, we started using subglottic suction tube, a closed suction catheter with the routine WAB bundle, and then our CRBSI rates came down. Because each context is different, we may be having scarcity of manpower, we might not be having 2 nurses to do an open suction. So better to do closed suction in those circumstances. It has to be multidisciplinary. Each and every stakeholder in infection control team is important. It could be the biomedical engineer, it could be the CSSD in charge, it could be the infection control nurse, an ID person, or a microbiologist. And infection control is a profession. So we need to have a very, very professional approach, serious approach, following the protocols very, very religiously so that we bring down the numbers and prevent the attributable mortality, avoidable mortality, which is happening in our ICUs and hospitals. Every breakthrough requires a break with the past, and we need to change our cultures. Infections do happen in our hospitals. This is a myth, and this has to be broken. This implies an interruption in the standard operating procedure. We have to relearn, we have to change ourselves. Interruption introduces efficiencies. Inefficiencies introduces error. Error introduces shame and guilt. is it any wonder why we resist change? So we have to change. We have to change to improve our healthcare outcomes. We have to change to improve outcomes of the patient. We have to keep our patients at the center of whatever we do. We have to make our healthcare safer, not only for our patients, but for ourselves also. Whatever we practice, same will be practiced when we require it or while we are being exposed in and out to these bugs in our hospitals. At the end, I like to quote late President Abraham Lincoln: when the occasion is piled high with difficulty, rise with it, think anew and act anew. Thank you. Thanks for the opportunity. I like to have comments and questions.
Thank you, Dr. Yash. A very wonderful session and a very
Yes.
insightful knowledge from your end on this wonderful topic, a need of an hour. I would like to invite members and audience over here for question answers. Before that, I've sent a form in the chat box. People who wants to attend the future sessions can fill up the form. And if you want the recording of this session, can also fill up the form with the email address and we can send it across. Once again, as Mr. Yash mentioned in his disclaimer, we don't have any commercial interest in these forums, and these are all free sessions. So if anybody needs to attend the future sessions, we are inviting some international speakers as well. And we do these sessions every fortnight. So with this note, I would like to invite members on the board for question answers. I see Dr. Bukhari's hand up. Dr. Bukhari, would you like to ask your question?
Thank you so much. It is not answered in question. And first of all, I appreciate Dr. Yash Javeri.
Before Dr. Bukhari, just before, sir, can you switch off your sharing screen? Meanwhile, when he's till the time he's switching off his sharing screen, you can ask the question. I think it's taking time.
Okay, thank you so much, Mr. Saurabh. And first of all, I appreciate Dr. Yash Javeri for addressing very, very important topic. And we usually saw these all problems during our COVID. And you give very beautiful suggestions about how to prevent all these things. And you know, in Pakistan and India, the big problem is the population, and the population whenever any patient is admitted in hospital here in Pakistan, 5 to 6 people will come to stay with him. And if the hospital administration is not allowing them, there is a fight or something. The very important thing is that the exogenous infection to control. The important thing you told everything, hygiene, personal hygiene, using PPI, use all that, but the education is very important. Education to the patient, education to the patient's relative, patient attendants, education for the for hospitals personals, not only the doctors but also the nurses, also ward boys, and also all other things. So the education is very important. And nowadays, if you educate, try to educate, they become very irritated. So again, we have to become very humble. And all these things we cannot apply, as you told, that the hand washing, everybody knows, personal hygiene, everybody knows. And why not all knowing all these things in hospitals, especially in public sector hospitals? Because there is a lack of awareness of these all problems, all issues to the hospital personnels and to the patient and patient relatives. Hopes, inshallah, on these platforms and in other platforms, we have to work to publicly in the patients, in the public, to create the awareness that this hospital acquired infection is not due to anything else, it is due to you. And as you told, very beautiful thing that it is a preventable. There are so many things that we can prevent, and these prevention is better than the treatment, and the prevention, a small thing, is better than the treatment for the larger thing, as you told. Hopefully, inshallah, due to these all awareness, one day, you know that in India and Pakistan and all other poor countries, hospital acquired infection is greater as compared to America and others,
Absolutely.
because there are very strict rule, and the people know those. Thank you so much.
Thank you, Dr.
Dr. Rani, can you please raise your question?
Thank you so much for giving me the opportunity, and hello to Dr. Yash. This is that since last 8 years, I've been working on infection control and prevention, and my PhD was on that. And we have worked on system process mapping. So I would like to know what is the opinion of Dr. Yash about having a systems approach and bringing these bundles in the format of process mapping and training as per the processes, rather than just a bundle, individual bundles. So I would like to know that.
Yeah. Thank you for the wonderful question, Dr. Usha. So yes, we have to have processes and we need to evaluate our processes. Not only evaluate by our resource, that our infection control nurse or our intensivist or our respiratory therapist doing it. We need to peer review each other. My ICU being reviewed by other surgical ICU guy, my hospital being reviewed by somebody else. And also the process has to be independent of the doer. The doer and checker cannot be the same. What is happening in most of our facilities, the person who is doing, he himself or herself is checking. This has to change. Second important thing, we have to bring automation to the process. All infection control processes have to have some automation. The bundle approach is all or none phenomena. If you do not follow one particular bundle, your score for that particular patient becomes 0. So if there is a big reason, you should be mentioning that. Going on to how to improve our processes, yes, peer review, independent review, our processes being reviewed by some external agencies, and there is a big amount of AI which is coming into it now, like what was prevalent in during COVID, how the PPE was removed or where they should monitor remotely with a camera, CCTV camera. So we need to bring more of technology into infection control prevention, less of human interface. If we bring less of human interface, the chances of error will be decreased. So a lot has to happen, but we have to set our basics right first. We have to be having a passion towards infection prevention. Thank you, Dr. Usha. You would like to add something else on this?
Yes, sir. We have developed a bundle for neonatal ICU. And considering that the babies are, we cannot use single bundle. So what we did is we trained the nurses, we sat with them and we did a process mapping of each processes that has been carried out in the hospital, especially in NICU. And with that, when we went with the systems approach, even during COVID-19, we did not see the surge of healthcare associated infections. And we could really curb at least 50% of mortality in HAI. So we have published around 8 papers till now on this topic. So great work we have done. A different approach, management approach we have used, which has worked. Maybe perhaps we can share it in future.
So whatever we do has to be contextual, as we discussed about. So think global, act local, and be vocal. Whatever
Yes,
right
of course.
practices we find, we have to share it. And please share that. Please share that. Dr. Monica, madam, will you like to
Sure.
give some
Thank
comments?
Oh, sure. Thank you for a great presentation. And it's always nice to revisit the concept of healthcare acquired infection, especially since we all had to learn it together during the pandemic, even if we weren't specifically paying attention to it. Hand washings at the individual level. If we go to restaurants here, you will see signs above the sinks. All employees must wash hands before returning to work. Simple things like that without belaboring, badgering patients and their families, simple signs like that. Text notifications as people are entering a hospital or healthcare facility. If you want to keep your family member well, please ensure that you wash your hand. Please keep surfaces clean. Please stay away if you have a droplet or an airborne, potential infection. And I like what Dr. Usha was talking about and what you had mentioned about AI, in that AI can really play a role in early detection of healthcare-acquired infections by analyzing data. If you have any electronic health record keeping, that would be great. And looking for patterns or predicting infection outbreaks. Anything that can involve telemonitoring, like you had the CCTV cameras that you had mentioned earlier. I think the more data that is collected, the more granular the information becomes, the more that you can process it. I think then you would be able to compare apples to apples across institutions, because I think the infection risk cannot be applied broadly from one place to another, from one department to another, from an outpatient to an inpatient facility. I think that there's nuances that are unique to each healthcare setting. And then if you have enough centers, enough places that are inputting data, I think you'll have so much information to be able to incorporate AI on a systems level, and then simple techniques like hand washing signs on a personal level. I think that's all I wanted to share, but it was a fantastic presentation. Thank you for your input.
Thanks for the comments. Thank you. One more thing I'd like to point out here. See, everyone has to be serious. It is not one person's job, as Dr. Monica also pointed out. Second most important thing is, now in India also, the healthcare insurance companies, the TPA companies, they're asking, this patient was admitted with head injury. Now, why should we pay you for pneumonia? They have started asking these questions. And we already are having so many legal suits because of hospital-acquired infections. The scenario is not much different from US, but still we are not that serious about prevention of HAI as are our Western colleagues. The problem in ICU is all our job is undone because of an HAI. We have a serious patient with ARDS, we treat the patient for 15 days, and now the patient has VAP. And the second hit, and most of the time, when such a critically ill patient will end up with a mortality because of secondary infections.
Thank you, Dr. Yash. Do we have any other questions? Dr. Angelique, you want to speak anything?
Thank you. Thank you, Dr. Javeri, also
Thank
for a
you.
very informative
Good morning.
morning. Yes, it is morning. So I just want to make a comment on the CLEPSI. I'm part of a group of they affiliated with me, is the critical care technologist in one of the hospitals in Pretoria, and they managed to bring down the CLEPSI infections to less than 1% in that specific hospital, and they're also using an electronic health record and an IT system which they communicate with the doctors and with the personnel. And I must say it made a huge difference in that hospital. And it's so that other hospitals also now are asking them to come and help, especially on the CLEPSI side. So, but it's exactly what you have said. They are following very strict protocols, no long nails, nothing. You need to be dressed. You need to be, the normal, as Monica said, it's lying in the simplicity and just following the simple rules that's out there and not taking shortcuts. That's how you also bring down stuff like CLEPSI. But thank you so much. Very wonderful lecture. Thanks.
Thank you, Doctor. Pleasure to have you.
So if you don't have questions, okay, so there's another question on the Facebook, which I can see. It's what can be the government role for preventing a regular audit? So for example, when you set up an hospital, you get, you get NABH certifications and all other certifications. So what is the government and authority roles for making sure that these kind of infections are properly managed at a hospital level? And if are there any penalties or anything which can be implied?
One nice question. Thanks for the question. So government is serious about it, although it's not high on their priority as anything in healthcare in this part of the world. But there is some seriousness. There are documents from National Center for Disease Control and Ministry of Health and Family Welfare and all the premium medical institutes about infection prevention. And at times they give free trainings also for all the healthcare providers, regardless of which public or private setup they are working in. The second part is NABH has made it mandatory to have your HAI data, to display your HAI data. Each ICU, if I talk about, each ICU has to display the monthly data of CRBSI, WAP, SSI, and COTI on their display boards for public display. The patients can come and read the data. Oh, this ICU is having CRBSI. But sadly, the public awareness also on HAI is not very high unless the patient is very much aware about the healthcare priorities. He is not into the HAI prevention. Another important thing is the institute has to take HAI prevention seriously themselves. They need to have a political will. If they are politically motivated, the head of institute is serious about HAI prevention, it will happen. If they are not serious, nobody can change the practice in that particular institute. So political will is must at every level, and we need to be stewards for HAI in best of our capacity, individual or a society aspect or from an administrative role. Everyone has to contribute for prevention of HAI. A lot of good thing has been happening on social media also. In fact, mainstream media, television and radio, there are many telecasts about prevention of hand infections, especially diarrheal illness, good hand hygiene. So there have been increased awareness, and there was a paper which was published probably few days back in Nature, where the what was the campaign? Clean India campaign was hauled because by virtue of Clean India campaign, the diarrheal illness load and mortality with diarrheal illness has come down drastically. So things are changing, but we have a big population and there needs to be cultural change. So effort is required from all the dimensions.
Thank you, sir. Wonderful answer. And I thank you for this session. I think with this session, we don't have any other questions. So we will wind up the session with a positive note. And thank you so much for spending your weekend morning with us, enlightening us for this session. So with this note, we would like to close the session. The members and doctors for joining the session. We will send the recording, whoever has joined the form. And for next sessions, we will also invite you guys. Thank you so much.
Thank you, Dr. Saurabh. Thank you, Dr. Monica. Thank you, Dr.
Thanks.
Thank you.